literally just flown in and landed at Manchester Airport, so I don't know where from. Budapest. So I hope you're all right. And no, okay. Bear with Mark. He's joined by Erica Opare from Mirla Health and James Chapman from Decently. So please give them a warm welcome. They're going to be talking. Thank you. They're going to be talking about the use of data sharing to address health inequalities and the use of data for population health management. Thank you.
I think I'm going to be slurring rather than talking. They talk about a wandering Jew, so I epitomise that to some degree. Thank you for the invitation. Gareth, that was brilliant. And I'm going to be a wee bit challenging, but in the panel, so I'm not going to let you away with, doing to patients. I'm going to explore working with patients, and I think that's key to me. I also got slightly nervous because I'm here not as a former clinician or as a dreaded management consultant, but as a patient with type 2 diabetes. So when we talk about chronic kidney disease, and we talk about hypertension, we talk about liver, I sit there thinking comorbidities, oh my goodness me, I'm really nervous. But I think the thing I'd like to explore when we get into the panel is not what we can do for patients in a clinical way, but what we can do ourselves. And one of the things I'd like to explore, if it's appropriate, is not how we take clinical data and necessarily jump into stuff, but I'd like to explore, after our introductions, maybe what I can do to better self-manage. The best patient, dare I say, is the patient who isn't a patient or can self-manage where appropriate. So that I'd like to get into a little bit of that. Maybe explore digital maturity in terms of not organizations or cities, but of citizens and patients, because I think, again, there's something to explore there. But everybody knows Gareth. Start here, reversing chivalry. I don't think you're allowed to be chivalrous anymore, are you? No? So. Sure. Tell us who you are.
Hi, my name's James Chapman. I'm one of the co-founders of a digital health company called Decently. We relocated to the Greater Manchester region in the summer after successfully landing some investment, which was fantastic. We specifically work with neuro rehab centres, so hospital units, clinics that are looking after people who've had some kind of acquired brain injury. For people who've had some experience of that, you probably know that this can happen at any point, at any time, to anyone. It's icy outside today. This could have resulted from a fall, could be a motorbike accident, could be a sports injury. But what a lot of people don't realise is that one of the conditions people live with after a brain injury is to do with changes in their behaviour. So we've been working with clinicians for the last 2 years to build a new digital platform called Mello. And Mello helps to look at the behaviours and changes of behaviours in neuro rehab patients using things like big data and AI to make their care better.
Great, thank you.
Thank you. So good morning, everybody. My name is Erica, and I'm the founder of Mirla Health. I'm also a pharmacist, and I've had experience in commission support in community and also hospital. And my startup was actually centred around menopause, supporting women going through menopause, and look at the connection between voice and hormones.
Great. Gareth, do you want to add anything? You've had your own independent slot.
I haven't spoken enough yet, so yeah.
So you've done your bit. So I think the first thing, and I'm being a bit naughty because I've been travelling a little bit and so wasn't involved in the sort of panel briefing, so I'm allowed to go off-piste a little bit.
We'll throw these away then.
Well, not quite. No, I did some quick reading going, right, I'll make sure I touch on these, so don't throw them away. But I think for me, there's something, first of all, about common definitions. Because I sometimes think we get carried away, so we talk about health inequalities, we talk about data sharing, we talk about population health management. And these are quite clinical, scientific, technology terms. What do we mean by health inequality? What do we mean by data sharing? If you went out on the street, and I live in Salford, as you can tell from my accent, thanks very much. Yeah, it's still funny at this time of the morning with no sleep. Yes, I know. Yeah, teaching the English some culture. I know. Don't start. Right. But if I went to Salford Precinct and said, "Hi, how's your digital maturity? Hey, we're doing stuff with you on population health management. We're managing your lipids. How's your hypertension?" We've got a whole parlance and lexicon that, dare I say, potentially increases health inequities. Just to the panel, what are you doing in your independent work to make sure we talk the language of patients and citizens and do what they want and what they need, not what we think they need? Gareth? Yeah, go on.
Really appropriate challenge, and also please don't prejudge the panel. We're not particularly well prepped, actually, so just throw us some questions and we'll do our best to answer them. So in terms of what, Yes, I mean, I think, I took that very much from a sort of a technocratic population level in terms of what is it we can do to really shift things in a major way. But I mean, there's a couple of pieces, isn't there? I think one of the bits I didn't talk about was co-production, and that's what you referenced in your intro. So I think one of the the huge sort of ironies really is we co-produce information all the time in our lives, don't we? Whether that's online shopping or ordering flights or taxis or whatever it's usual that we interface with a service. Now for healthcare, that is just that's a rarity, isn't it? I mean, it almost never happens. So there's a lot we need to do to encourage people, as you were describing, to set up systems such that people can co-produce health data, whether that's a diabetes sensor, whether that's step counts, whether that's alerts around activity. There's a lot we can do there. We've started, there's an early proof of value over in Tameside around using a patient-held record to get that type of information into our systems. And clearly MFT, so I don't work for Manchester Foundation just directly, but they've got a big program there with their patient portal whereby booking and scheduling, pre-op assessments, all these types of things can come in. So we're asking people to take ownership and really be co-partners in their healthcare. But the other piece, as you rightly describe, is that will hit a certain sector. And the risk, as I was saying before, is that you can actually worsen health inequalities. So I think one of the things that's really important is that when we're designing these new approaches, we have a really close working relationship with patient groups. So we've got a strong PPI group at Health Innovation Manchester. Everything that we do is sense checked with them, particularly around the data sharing. So if we're going to share data, trust is absolutely essential, and we've actually referenced that in some of our sort of formal strategy and governance papers. If the trust has to be there between the data sharers, the data owners, and the citizen, and if we lose that, then we've really missed a huge opportunity. So there's something around design, there's something around trust, and then I think there's the other piece is that ongoing engagement as part of any development to ensure that whatever it is that we're doing to build, it's always done in an iterative way with citizens. There's quite a lot there, but
Yeah, no. And I'll give the others, I'd like to hear from Erica about sort of the menopause, where you've been sort of engaging with end users and understanding their needs, and equally from the Euro point of view, which I'm sure will bring with it its challenges as well. But Erica, how have you been finding out user needs and health inequality issues that may occur in menopause? Not an area I know much about. Yet, I'm not old enough.
So what we've been doing is we're holding user groups, and we found there's a great inequality, especially with black and ethnic minority groups, which is unfortunate. We found they've been suffering in silence. My mother, she suffered horrendously. She had a hysterectomy. And being a healthcare professional, when she was going through her symptoms, I wasn't really aware of the symptoms, which was a bit of a shame because I thought, I'm supposed to be a pharmacist, I'm supposed to know how things work with HRT and so forth. So I really took that passion to be able to help women going through this, and everyone will go through this. It's estimated, I think, in 2025 that 1 billion will be going through menopause, so it's something that isn't going away. So we've been holding focus groups, and we've been just gleaning information from them, and we found that indeed women are suffering in silence, and unfortunately women from low socioeconomic backgrounds, women that perhaps have comorbidities as well, don't tend to go until it's too late. When it's made by too late, they're really suffering horrendously. It's affecting their mental health. And recently there's been a nice guidance as well that's gone to consultation, adding CBT as one of the modes of helping women going through menopause. So that's what we've been finding.
Brilliant, thank you. And I think caregivers may also come into your focus group work as well, James, because sometimes there might be somebody who's not able or has full capacity, but I'm making assumptions.
Yeah, absolutely. We've started, at the clinical coalface. So Mello is used in a hospital environment, but we very much see it that we don't want it to just be something that's done to the patient. It can actually help support the patient, support their family, their carer as well. Around brain injury specifically, you said about making that real for people on the street. About 25% of all critical care admissions into Salford Royal up the road is as a result of a brain injury. So, this is affecting people on a daily basis across Manchester. But when you dig into that, there are inequalities. There's more brain injuries happen in homeless populations, in people who've experienced domestic violence. There's studies out there that suggest that ethnic minorities are more prevalent for acquired brain injury, that's dementia and stroke, and also around the increasing number of older people. With people living longer, there's more chance of people over the age of 65 suffering from a brain injury, and then we know that it's harder for those populations to access the care that they need. So we're trying to build something that could, in the longer term, go out into the community, go home with someone, and actually be part of their ongoing recovery beyond the hospital.
So nice to hear we're beginning to engage, understand what user needs are. How is digital literacy an issue with the general population, with specific health inequality populations as well? I mean, I've been here for 18 years, I've developed systems, not as a software person, but I still struggle, even though we've got a shared care record. When I had mental health problems that my psychiatrist didn't know what my endocrinologist was doing, and my endocrinologist didn't know what my hepatologist, my liver guy, was doing. And the shared care record was my wife. So, you know, despite the talk of systems, despite the talk of it all joining up, I still sometimes feel, you know, as a diabetic, I can possibly read some of my record, but I can't write to it. I can't put in, as you say, my freestyle, my blood glucose meter. I will not advertise any particular brand, but I can't put in my blood glucose meter readings. I can't put in my pedometer stuff. So there's a lot of talk, and you know, 30 years ago in Scotland, we installed a Cerner electronic health record system in 1993. You know, we've been around for a while talking about this stuff. What's going to change the mentality from, you know, citizens who are looking at this all the time, playing games, watching YouTube, doing really valuable stuff, to begin to do health stuff on it? What needs to happen, and how are you three people perhaps facilitating that? I'm going to pick on Gareth again to start. Go on.
So, I mean, you're absolutely right, and you know, I think that sort of interoperability challenge is experienced between professionals, and it's between professionals and the service. And I think to a great extent, we're constrained by the technology and the level of digitization across the system. When we say to patients, you know, do you want your information shared? People expect that the information shared, and as you described, Mark, they actually expect to be able to contribute to it. I mean, why would you not? So I mean, I don't have, you know, I don't have an answer actually. I mean, a lot of it is around interoperability. It's around how we actually, you know, encourage tech vendors to use open standards and communicate in that way. But I think it's also around, you know, small proof of values. So the sort of things that we're doing with, like I said, with the PHR in Tameside, or with integration with the NHS app as a single front door. It's when people see a consistent approach and aren't met by a plethora of systems and different windows, that then I think the momentum will really start to be gained, because people will see that simplicity, and they'll also understand that their data is being looked at and they are actually contributing. At the minute, I don't think we have that compact between the service and the citizen. We make it too difficult for people.
Yeah. Erica, go back to your mum, if I may. You know, your system's live, it's been co-created, it's working. What would need to happen for your mum to engage with your sort of menopause app, your menopause support service?
I think there needs to be buy-in. For example, she will need to feel included, that the services are made for her. So initially, the early adoption, when I say the stage, she needs to be consulted, and other women within a similar situation will need to be included, whereby when it's been created, think, okay, this service is for me. Because she was very technical, she was very good, she was always on her phone and, you know, YouTube and so forth. So she wouldn't find a problem, but I think the early adoption of the innovative idea, she will need to be consulted in an early stage for her to actually get that buy-in, I think.
Yeah, it's interesting. My own mum, who's sadly no longer with us, but was, you know, very into the mobile phone, but could only, you know, wouldn't do WhatsApp on it, interestingly enough. And ended up using Words for Friends, or Words with Friends, whatever that thing is, as a sort of informal caring tool. And if she didn't post a word back within 15 minutes, I got a bit nervous, you know, and we'd text her and she'd say, oh, I just fell asleep on the couch or whatever, until she didn't respond, and it was a bit more serious. But, you know, joking aside, and not, there are other mechanisms by which, not the formal healthcare stuff, we can monitor people. And I wonder from your side, you know, where are you? You've talked about starting with a clinical perspective, beginning to work with patients and caregivers. Are they digitally literate enough? Are they willing to learn? Is there a gap between what you want them to do and what they're able to do?
I think there is a huge gap, and I think that exists within the hospitals. You know, it's really heartening to see the slides about the GM ambition, but I think on the ground there's still a long way to go. You know, give you a real example, we've just had to buy some tablet devices for the hospital that we're working with because they really love our technology, but they don't have the kit to use it. You know, so I think there is a disparity there. You know, there's a will, there's an ambition, but there needs to be more investment at the ground level. I think when you come to talk to patients and families, which we've been doing a lot of, because we don't want our technology to be just done behind the scenes, we want them to be involved in it and understand it, then I think there is an interest and a willingness around what the clinicians are doing with the data and why they're doing it. And I think if you bring patients and families with you and you explain the benefits to them and how it's going to help their loved one maybe get out of hospital quicker, get home quicker, get back to some kind of normality, they see that giving data to a technology company is not the end of the world. You know, we all give our technology every day to shopping companies through our browsing habits, but there seems to be a reticence to allow people to use health data for the benefit of patients, and I think we can all probably help to break down some of those barriers.
Yeah, it's interesting going back to the app I was using informally. I'm not so worried about the NHS, and I trust that. I'm not even so worried about big pharma. Excuse me, I've got a bit of a frog in my throat. But what I'm worried about is the Facebooks and the Amazons, because every time I played a word, having bought something for my son and Lego, it kept popping up and going, do you want some more Lego? Do you want some more Lego? And I was like, no, I don't want some more Lego. And where did I give you permission to keep advertising and marketing to me? You touched, Gareth, on trust. I think there's something for me that says, are patients trusting the technology across the systems that you have? Is there that fear that, I can do my banking, I can do my holidays, I can do lots of stuff, but health, I don't want to do health. What's your collective experience of people trusting the systems and wanting to use the systems?
So I think people do or would trust the systems. I think that bit about engagement, and particularly whenever we're progressing something around data sharing, really having that strong patient engagement and system engagement and being absolutely clear about what this means and why we're doing it. And actually being, as I said before, being surprised that people say, well, why are you not sharing this? You know, I think you know, as a healthcare professional, as a patient myself, you know, I'm in a good place with that. I think the challenge is around frustrations, actually, both for the professionals and also for patients. I'm picking up on James's point. As I said before, you know, I still do clinical practice. I get as frustrated as everybody else when the laptop won't turn on. You know, I can stand here with population level slides, but on the morning I'm pressing this button trying to log on DPR. You know, I know what that feels like. So I think we've got that frustration from a patient perspective and a professional perspective, and it's really trying to work with people to manage those expectations alongside the vision for change, but at the same time saying, look, this conversation or this intervention is a small part of that vision, and we know that it's difficult.
Yeah. And how James, Erica, how have you, in developing your solutions, balanced what I'd call accessibility with consent and trust? Because I don't know about anybody else here, but it seems to be so litigious now. I get these things that are 24 pages long, you know, and the Microsoft says, you're now signing up to this, and you go, tick. I mean, does anybody read these things? No? You know, so that seems a litigious document. It's building trust or not. You know, how do we balance that sort of information sharing and trust? So when you're talking about collecting data, have you done work with patients? Are you planning to do work with patients and citizens around trying to find that balance between informed consent, governance, and yet being accessible?
Yes would be the short answer. It's been we've been going for just over 2 years, and I'd say, you know, probably 3/4 of that time has been focused around things like information governance, compliance, cyber security, clinical safety. And, you know, as a startup, you know, I guess a lot of people have maybe worked in a startup or had an idea themselves. You know, when you go into health, I don't think you appreciate that there's a lot of barriers that you need to overcome. But I think that's for good reason, because if somebody is going to trust your technology to put patient data in, then the minute that you do something wrong with that data, you lose it, you misuse it, you do something that you weren't supposed to do with it in the first place, then you erode that trust. So I think we see it as an enabler for the company, for the platform going forwards, but it has been a huge journey just to get to that stage where you can actually hold patient data.
Yeah, it's not easy.
Yeah.
Yeah, I'm actually at that stage yet, but the healthcare accelerator has been drummed in us in our heads from a very early stage, the importance of information governance. So yeah, for sure, I totally understand what James is saying.
DTACs and
Yeah.
all these different things, and
Indeed,
again
yeah.
some confusion. Is it NICE driven? Is it MHRA driven? Etc. Etc. I just want to ask the audience a little bit. How many people in the audience have got access to their health records? Who wants access to the health records but can't? Who uses the NHS app? Right, and who knows the winning lottery numbers for Saturday night? Actually, my cousin won the lottery, would you believe? 25 years ago, Barry in Glasgow won 4.6 million. He's miserable, by the way, but so it's not all good. I just want to go back to some practicalities, and you know, in the last few minutes that we've got, just some sort of top tips to other people, you know, needing to navigate co-creation, governance and all the rest of it. And I just want to give a little bit of a plug on the records bit. There's a gentleman who many of you will know. I think he's across the Pennines, but as a Scotsman, my geography's not too good, but he's in Derby. That's not quite Greater Manchester, is it? No.
No.
Okay, but can I quote him here? Is that allowed? Am I allowed to quote somebody from Derby? Derby, however you say it. What do I know? There's a great guy I know, a GP called Amir Hanan. Anybody know Amir? No? Yeah, look up Amir Hanan. So Amir took on board, what's that guy that killed all the people, the doctor? Chapman. He took on Chapman's practice, sorry, jet lag, and stupidity, and age. So he took on Chapman's practice, and one of the things he promised when he took it on was complete and utter data transparency. He now has, across all ethnic minorities, thousands and thousands of patients harnessing, using, utilising their record, not just for appointments, but to look at diagnoses, to look at a whole bunch of stuff. So I think there's something interesting to learn from a practitioner there who has really, I mean, he's knackered, but he's really been an advocate for patients. What sort of lessons would you give to people here? What top tips would you give to them in terms of navigating the boundaries, you know, being a champion, but at the same time having a work-life balance? Because it seems a lot of times that you really have to invest your life and soul in navigating this. What sort of tips would you say? I'm getting the 5-minute warning.
That's difficult. So, I mean, Amir's a great. So you can mention Amir because he's a Manchester GP, so he's in Hyde.
Is he in Hyde?
Yeah. So we've done a lot of work with Amir, particularly around patient access and understanding the work that he's done, so that we've got that that screen, that sort of privacy screen, if you like. And Amir's worked really closely with us on in terms of what is it we scroll through to ensure people are, you know, in a good place before they look at their own information. So, as you rightly say, an absolute trailblazer in a really difficult situation. Tips. Difficult.
Well, let's put it another way. If we were all to leave this room and we want to try and engage our families this evening in conversation about data sharing, population health management, great topics. I'll try bring them up at the table, see how they go down. But in seriousness, how could we make our families more health and data literate? What sort of things could we do individually and collectively as a group to try and begin to get those who don't use the NHS app to use it, perhaps? Or what's the use case? What's in it for me?
So, you know, I think it's to me it's that discrepancy between what you do in the health part of your life versus the 95% of everything else. You know, we interact with one another, we interact with services all the time. You know, my kids are online almost permanently. You know, this is just normal, and it's almost sort of reframing in that and saying, well, why would we not do that for health and care? It's absolutely in all of our interest to interact with health tech and understand our risk factors, understand our mobility, understand how we can share information. So I think it's just drawing parallels, bringing it to life in that way, but at the same time providing that assurance around, look, this is safe. There are an enormous number of processes wrapped around this, you know, and they, without having any objective evidence, I think I would say, look, you know, this is probably the safest way you can share your data compared to the stuff that you do in your life without even thinking about it.
James?
If it was a family member or a friend and they said, you know, I'm suffering with this condition, or I want to lose weight, stop smoking, you know, trying to make it very real, I'd say don't use Google. You know, there's a lot of really kind of unsafe apps out there on the market, and you know, there's an organisation that we work with called Opare, who they specifically exist to look at the clinical safety of apps. So be careful what you're just downloading. Go to a kind of reputable source. Speak to your GP. They have access to clinical technologies that have been proven that have been proven to be safe and effective. So yeah, that would be my advice.
Okay. And Erica, in the sort of menopause and world?
Well, I was actually thinking of something different. But I think to encourage people to actually use more technological data that's, I guess, more user-friendly. Everyone's collecting data to some point, so to be able to encourage that, let them be able to not donate, but to also give the data. So for example, maybe their steps, I'm now wearing a digital watch. I could be able to show what I'm doing in terms of my health, give that to my GP. We're nowhere near there yet, I don't think, but something of that sort would really encourage people to get more buy-in, especially the NHS app, I think.
Fantastic.
Yeah.
So I think we're back on time. Are we back on time?
We are. I think we've got time for a question now, or two.
Are we sure you're not going to show me a sign and tell me off or something?
I'm not going to drag you off.
I've been on stage before and I've seen little sort of red dots like moving around. I'm like, okay, maybe I am over time. Any questions from the floor?
There is a question from the...
Oh, from the online?
Yeah.
Oh, that's so digital. Oh, that's so inclusive.
It's working, that's great. So the question's been raised by Alex Hernandez, who is a colleague of mine at One Health Tech, actually. And her question was around engagement, and she said obviously early engagement is important, but how early do you think that engagement should take place, and how early is engagement actually happening across Greater Manchester?
So, Erica, let's start with you. We'll come to you in a second. We'll give you time to prepare. Erica, early. How early is early?
Yeah, from the offset, I think literally the idea of conception, literally to get as many focus groups as possible, to get them involved as possible, yeah, from the beginning, I would say.
Okay. Mirla?
Yeah, I'd echo that. We probably spent the first 12 months talking to people before we started building anything.
And so my question, taking that question and saying, so when you showed all this wonderful stuff, Gareth, and I was like, wow, how could I as a patient, possibly with some of those comorbidities, also access that data and start to challenge, support, co-creatively work with the system, say, well, I'd like that injection or I'd like this. So give me enough information that I can begin to be an advocate for my own health. So is that something you're thinking about in terms of that engagement early enough, et cetera, et cetera?
Yeah, so I mean, I think the answer is, with all this is, as early as possible, isn't it? The sooner we engage, the better. I think the questions need to be really structured, because I think it's important if we're going to get sort of valuable engagement, valuable feedback. We need to be really careful about what's the question we're asking. So careful is the wrong word, but sort of focused, I think. As far as I know, Mark, I don't think that information is available in the public domain. There's no reason that it shouldn't be, but I don't think we've actually taken it to that level of saying, look at this heat map here and where am I on that heat map? But you're absolutely right, to sort of build engagement and an awareness, then that's what we should be doing.
So I'm going to publicly request a meeting with you later to come and have a chat about that. Would that be okay?
That's absolutely fine. Yeah.
Right, did you hear that? You said yes.
I didn't promise to do anything on the back of the meeting, but yeah, I'm happy to meet.
I know where you live. I've got a heat map. Thank you to our panel. Thank you to you for listening. And I'm going to hand over now to you to introduce. So should we run away? Should we give them all a clap and then run away?
Give them a clap.
Thanks a lot. Thank you.
Now you can all run away. Thank you very, very much. A couple of